Welcome. Today we're going to be going over parenteral nutrition or total parenteral nutrition, TPN or PN, just a couple different ways you might hear it said. So my name is Ranson Thomas and I'm teaching at Santa Fe College. So let's get started. So to begin, at Santa Fe, we use our concepts. So the concept that this course falls under, this class falls under, is regulation, right? And so regulation is how we define it is it's the processes that your body goes through to keep itself functioning, right? It's what it does to ensure that everything works as it's supposed to, that you have enough energy. And so that's how TPN, relates to regulation is TPN or PN, parenteral nutrition. It's nutrition that we need, right? And so our nutrition, we have to have a certain amount of, nutritional requirements so that our body can function effectively. If we don't have that, then it doesn't work, right? So what are our nutritional requirements generally, right? If we were in class, be asking you all this, but since we're not, just to kind of go over, there's some big ones, the macronutrients, right? And so that's talking about carbohydrates, fats, proteins. We have to have enough of all three of those. We also need a certain amount of water every day. Again, usually 2 liters, but that depends on a lot of things. We need a certain number of calories. We usually say, about 2,000 calories is what you usually see thrown out as the, quote unquote, normal for our calorie intake, but that can change. We need a certain amount of micronutrients as well. So things like our vitamins, minerals, our electrolytes, all those, okay? Those can be altered in a variety of different ways. So your activity level changes, maybe your electrolytes, your calories, your water needed to maintain your current level of functioning and potentially your current weight. Being sick, being injured, those can increase your metabolic demands for, calories, for fluid, for a lot of stuff. So there's a lot of things that can alter this. Now, when we're talking about parenteral nutrition, we are talking specifically about nutrition that is going to be administered parenterally, right? So enteral nutrition, when we say enteral, we're talking about nutrition that's going in via the GI tract or the gastrointestinal tract. So some examples of enteral nutrition would be just eating. When you eat, that's enteral nutrition. A gastric tube, any kind of gastric tube, it's still using the GI tract, right? An NG tube, a nasogastric tube, same thing. It's going in enterally. Parenteral nutrition comes from para, right? With like the Greek or Latin, I'm not sure which, but the suffix, or excuse me, prefix para, which means next to, adjacent to, or also, that means it's going into your IV, basically. It's going into your IV. It's bypassing the GI system. And again, this is almost always done intravenously. So the reason why we might need to do this, there's a lot. Essentially, it's because we can't get the adequate nutrition that we need enterally. Either we're completely unable to eat or take anything via the GI route because of some GI dysfunction, or it could be the case that we actually can eat. We maybe have a G tube or something that's giving us nutrition that way, but it's not quite enough, or we want to increase it, right? We want to try to give even more, or we're trying to maybe wean somebody off of parenteral nutrition and get them back to where their GI system is working effectively, but it's not quite ready to do the entire job on its own. It still needs a little bit of help, right? So the difference there, when we say parenteral nutrition, that just means nutrition that's being delivered parenterally. When we say total parenteral nutrition, or TPN, that means all the nutrition that the person's getting is being delivered parenterally or through the IV system, right? So again, you'll kind of hear those two terms used interchangeably. Like somebody might be eating, but they still are getting parenteral nutrition, and somebody will still refer to it as TPN. Technically, that's not correct because it's not total, but again, it's not really something that people usually split hairs over. So but for our sake, just keep that in mind, right? Just that technically, if you want to be that guy that's a super stickler about stuff, it's not actually total parenteral nutrition. It's just PN. But again, most people just call it TPN. And then, yeah, like I said, a couple other things. So a big reason we do this is because when somebody's in the hospital, we get IV fluids usually. It's very common. Somebody comes in, they just get hooked up to a IV to make sure that their fluid status stays adequate. But IV fluids alone aren't sufficient to meet nutritional needs. If it's something like, let's take D5 half normal saline with like 20 milliequivalents of potassium chloride. That's a really common one, like D5 half in normal saline plus 20K. That has, it's obviously saline, it's salt water, basically. It also has some carbohydrates in it, right? The D5, the 5% dextrose. There's a little bit of dextrose, not very much though. It's really not enough to make much of a difference in terms of someone's nutritional needs. It's definitely not enough to hit 1,200 calories. And the 20 milliequivalents of potassium, again, that might be enough for somebody, depending on how fast it's going. Throughout the course of the day to meet their potassium needs, but there's a lot of other things. There's a lot of other electrolytes and vitamins and minerals we need as well, right? So it can meet some of those, but it can't meet everything. And so a lot of times if somebody's going to be NPO for, they can't take anything by mouth for a day while they're waiting for surgery, that's okay. We can just give them some IV fluid to keep them hydrated and to give them some basic support. But if somebody's going to be unable to eat or take in any enteral nutrition for more than a day or two, we're starting to look like they're going to need either to take in enteral nutrition or they're going to need to get some PN, because again, that's not really enough. And the average adult needs a minimum of 12 to 1,500 calories per day. That's like your basal metabolic rate. Like if you just lay in bed and are a bump on a log, you don't do anything, this is like the minimum of what you need, depending on age, size, things like that. So that's just important to know, because again, we got to make sure people are at least getting enough that they're not destroying their own tissues to keep themselves alive. So what is TPN? Well, or PN. So first off, there's two components to parenteral nutrition. There's what we call the hyperalimentation fluid, and then the lipids. And a lot of times people will call the hyperalimentation fluid the TPN, and then they'll call the lipids. But that's not entirely true. It's all parenteral nutrition, right? But oftentimes you'll hear people say the TPN or the PN is the yellow bag and the lipids are the white bag. They're correct that the lipids are the white bag, but technically the lipids are also part of the parenteral nutrition, right? Because it's also being delivered parenterally. But that being said, it's not all mixed together. And the reason for that is the hyperalimentation fluid, or the hyperal solution, that's made up of a base solution of dextrose and amino acids, right? Which amino acids are the building blocks for proteins, which again, your body needs. In addition, there'll also typically be some electrolytes, some vitamins and trace elements and minerals and things that the patient's going to need. So that's all kept together in a suspension. That is usually a big yellow bag. It looks just like a big yellow bag. The lipids are separate. So lipids are the fats. Now, the fats have to be given separately. They have to be kept in a separate bag, because fats are made out of oils, and oils, things that are soluble in oil, are not the same things that are soluble in water, right? So in other words, like if you think back to your when you learned about vitamins, you have your fat soluble and your water soluble. So you have like A, D, E, and K that are fat soluble. Everything else is water soluble. So basically, like if you've ever imagined putting some oil in a drop of water, or if you've ever seen like an oil spill or something where the oil kind of sits on the top of the water, it's separate from it. It's because it doesn't mix. They can't sustain a suspension together in any useful way. So if we put the lipids in the hyperal, it would like separate. It would be just like, it wouldn't work. It couldn't infuse together. It wouldn't be a stable solution, right? So we have to keep them separate to keep the solution stable. Now, the lipids, these are given with the hyperal, typically for a shorter period of time. It's also typically a smaller volume, right? And there's a picture of this coming up, so don't worry. Now, the lipids, in addition to all that stuff, the lipids may have egg yolks, that are used in the solution. So one of the things we want to check for before we give this, depending on the facility and the brands that we're using, we want to check our patients for allergies, so especially poultry allergies, because if the lipids do use poultry products, then obviously they might be allergic. Some other things that you might see in the Hyperal, there may be insulin included in it as well to help control the patient's blood sugar levels. Now, that's not always present, but it can be. You might also, again, very rarely, see heparin added in as well. That's usually only in neonates. And the reason that they do that is the heparin helps to keep the central line patent for longer and helps prevent infection, right? Because the heparin basically sticks to the interior lining of the central line, and it helps prevent bacteria and other bad stuff from sticking in there, and which might lead to central line infection or the central line clotting off. So again, that's not super seen in adults. It's usually just neonates, but it's things that might be in there. So this is what they look like. This is the Hyperal. This is the lipids, right? Now these are going to be given at the same time. Typically, you might see the Hyperal given on its own without the lipids. You will not see, and again, I could be wrong about this. You might see situations where it's the case. Personally, I have never seen this the case, and I have not heard any nurses tell me of any situations where it's been the case. As far as I'm aware, you will not see the lipids given by themselves. You'll always see the lipids given with the Hyperal. Now, again, I could be mistaken about that. If there's some situations, I could be wrong. But again, I've never seen that. But again, I don't want to say that it's never the case because I could be wrong about that. So usually what happens is these are given over, like we start our TPN cycle at night and it goes for 24 hours. So this bag will run for 24 hours or until it's emptied, obviously, because once it's empty, it can't run anymore. And then the lipids, when we hang this, we hang the lipids. The lipids, though, only go for 12 hours. And the reason is because the Hyperal lasts for 24 hours. The lipids last for 12 hours. Like the suspension that they're in only lasts for that long, right? So if you keep it up any longer, the suspension can start to break down and it's not actually going to be good for the patient. Potentially, it could be like really bad. So if they do need more lipids after this bag is finished in the 12 hours, they would need to have a separate bag of lipids that gets started. If not, what would happen is, if this is all they need, after that 12 hours, we would take the Hyperal down, or the lipids down, but the Hyperal would stay up and the Hyperal would keep running for the last 12 hours without the lipids until the new cycle starts up, which would then probably include both. Now, this beautiful, lovely drawing is one that I made just randomly in class one day when I was trying to show the students the setup. They were asking questions and we were over Zoom. We were not pre-recorded like this, but we were just doing it over Zoom. And I couldn't show them like I would normally do in class. And students needed some way to show it. So I just really, really quick threw together an MS Paint as best as my limited artistic abilities could do so. So obviously, before I recorded this, I wanted to find a picture that did y'all a little more justice. However, when I tried to find an image online, when I Google image searched for an image like this that would show this in a much better way, I actually got this exact image. Some student saved it, or maybe even a group of students saved it and put it on one of those study/cheat websites, where they give you all the answers or give you study material and stuff. And I couldn't find anything better. So I said, well, you know what? I guess I'm just the only game in town, which is why they put it up there and why it shows up on a Google image search. So, if it's good enough for everybody else, I guess it's good enough for y'all. So here it is. So this is how, and again, it's a little out of proportion, but this is kind of how the setup looks, right? So this is our IV pump, right? This is our, if we're using an Alaris pump, this is our Alaris pump, right? We're going to have two different channels. So the lipids and the Hyperal, they run together, but on separate channels, because they can be at different rates, right? Like this hyperal might be at like 70, and the lipids might be at like 20 mils per hour, right? And they run at different rates. It's just whatever's ordered, however much is ordered for the patient to get per hour, that's how much is going to run. They go through their own separate Alaris tubing. And then at the end of their Alaris tubing, so this represents the end of the tubing, what we do is we connect a filter on both sets. Now, this issue with the filters, depending on where you work, some hospitals use parenteral nutrition suppliers where their materials do not require filters at all. Some use product that does require a filter. So for our sake, we're going to pretend, as we always do here at Santa Fe, that you're in the absolute worst possible situation that requires you to do the most work and be the most bothered, right? So we're going to say there's filters, because if there's nothing, if we don't need filters on it, then what we would do is we would just connect this lipids to the lowest IV site before it enters the patient, and then they would run together. Instead, if we do need filters, what we do is there's two different types of filters. There's going to be a hyperal filter, and there's going to be a lipid filter. You'll know which one's which because on the labels themselves, they will tell you the micron size, right? And that's what determines it. You'll also be able to tell because the hyperal filter will have an extra Y site on it. The lipid filter will not have a Y site usually. There might, could be wrong. I don't know if there's some weird providers or manufacturers that might do it differently, but the hyperal filter will have a Y site, like an IV Y site. The lipid filter shouldn't. And then what happens is you connect the filter to the end of each Alaris tubing for its respective, product. And then the lipid filter at the end, you're going to connect it to that extra Y site that's on the hyperal filter. And then all that's going to run into the patient. The reason we do this is because, once again, the hyperal and the lipids, they can't stay together. They can't run in together for very long because it breaks down the suspension because it's an oil and, water soluble stuff. Once it gets into the bloodstream, though, everything's compatible in the blood. That's what we say. Everything, once it's in the blood, it's compatible. So this last little bit, it's maybe, a couple inches of IV tubing that they run into together before they get into the bloodstream. So it's not, there's no problem there. It's not going to stay in long enough for there to actually be an issue with the suspension, right? But we wouldn't want to connect them like right up here at the top of the channel, like right at the Y site that's up here, or run one as like a piggyback or something. Because first off, that means that only one is running at a time, which we don't want. But second off, we don't want them to be stuck together for the entire length of the tubing, right? So when we set this up, we want to spike our bags. We want to prime the tubing, prime the filter, right? We want to prime the filter so that we basically treat it like an extension of the IV tubing. And then we hook it all up to the patient, kind of like this diagram shows. And then lab, and then sim and clinical, if you have the ability to see it in clinical at some point, I or your instructor or somebody will kind of show you how this looks in practice, because I know this drawing, despite how nice it looks, it is not, still not true to life. It's beautiful, but like all art, it's just trying to imitate, reality. So here's a question, just something to think about. Your patient is receiving TPN for treatment of malnutrition. Which value would be the most helpful in evaluating the effectiveness of this treatment? A, blood glucose level, B, serum albumin level, C, serum phosphate level, D, hemoglobin and hematocrit. So if you want to take a second, pause the video or something and think about it, and then, think of what your guess is, and then you can unpause it and I'll tell you what the answer is and the rationale. So hopefully you actually did pause it. If not, please do so now, but or at least come up with an answer. So anyway, so the answer we would say would be the B, serum albumin level. And the reason for that is because serum albumin level is going to tell us, it's a measure basically of the amount of protein that the patient's getting, right? And so that's going to be, or the building blocks anyway of protein, the albumin and pre-albumin, that's kind of like the signals of how much protein usually the patient's getting or how much they have access to, how much of the building blocks they have access to. So that level It's going to help give us a picture of the overall nutrition of the patient. It's going to give us an indication of like, are they actually getting adequate nutrition or inadequate? Now, for some of the other options, the reason they're wrong, blood glucose level. First off, would we want to check that on a patient who's getting total parenteral nutrition? The answer is yes, we would. But the reason we would want to check that, first off, is not to check their overall nutrition level. We would want to check it to make sure their blood glucose levels are staying adequate. They're not getting too high or too low. Patients who are on parenteral nutrition, they can see spikes or drops in their blood glucose levels, even if they do not have diabetes or another disease like that. And the reason is because when we eat normally, we eat meals. Now, I don't know, maybe some of you have a constant stream of food going into your mouth. I know that's me, especially after the holidays, but your body doesn't have like a constant, consistent stream of food going into it. You've got periods where you might go many hours without eating, and then you eat a big meal. So your pancreas, when it creates insulin, it's kind of used to creating a lot and then taking a break, right? It's like a sprinter. It can sprint really fast, but then it's got to take a break, right? It can't just can't run a marathon, right? Which is what the TPN is basically asking it to do. It's saying, here's a constant stream of sugar and other nutrients, but sugar for the insulin, that you're going to need to deal with throughout the entire day. So the pancreas, again, it's used to sprinting. It can do really fast sprints, but it's not very good at marathon running. And that's what the TPN is asking it to do. It's like giving it a little bit all day long. As a result, you can sometimes see spikes or drops in a person's blood glucose level because, again, the pancreas it's kind of used to those peaks and troughs, which you're not getting. And so even though they don't have diabetes, it might still affect their blood glucose levels. So you are going to check it. The issue, though, and the reason it's not the answer to this question is because even though it's important, even though we want to check it, it's not an adequate assessment of malnutrition because blood glucose levels can change very rapidly. I mean, think about some of the rapid acting insulin we give. It can have an effect in as little as 15 to 30 minutes. If you eat a meal, again, 15 to 30 minutes. So that's not really, it can fluctuate from 75 to 300 in the matter of like hours or even sometimes less than an hour, right? So that's not a good measurement of how adequate your nutrition is because it can change so rapidly. It's so volatile, right? C, serum phosphate levels. Again, this is another thing that we will monitor, but it's more monitoring for complications of TPN, and it doesn't give us any indication of what their nutrition levels like. We're going to come back to the complication we're looking for with that later on. And then the last one, hemoglobin and hematocrit. This could be useful in some way, right? Because again, if you maybe are deprived of iron, you don't have enough nutrition, your hematocrit and your blood levels might be diminished because again, your body's not able to create the red blood cells it needs to everything. But this is kind of like a knock-on effect of malnutrition, right? It wouldn't be the most immediate thing you'd look at because there's a lot of other things that could cause it. It also would be, it's kind of like 2 or 3 steps removed from the immediate thing we're looking at, right? It's not like you're malnourished and so immediately your hematocrit drops. Like that's not exactly what happens, right? It's kind of a longer term problem that would result from like a long-term issue of malnutrition or something. So it's not going to be the best thing, the most useful in helping us evaluate. So the nursing care. First off, the special IV tubing, that's the filters. So the filters have to be attached at the end of the IV tubing. And again, it's basically just an extension of the IV tubing that has a filter on it. Now, the reason we use filters is because the suspensions, first off, obviously, there can be air embolisms that enter. The other thing, though, is that these suspensions of lipids and the hyperal, there are particles inside you, right? It's the sugar, the fat molecules and stuff. They can clump together and they can form like particulates that can get large enough that they can cause embolisms, right? And so the filter helps to catch any particles that have gotten too big, where like too much of the solute has become like crystallized together. And so when it detects that there's something that's like too big, the filter catches it so it can't pass through and potentially cause or maybe contribute to an embolism of some kind, right? Now, we almost always give PN through a central line or a PIC, which a PIC is a form of central line. I say almost always because I have seen patients get it through the peripheral IV. That is a very rare occurrence. It is not something that you are probably likely to see in your career, but it's something you might see. So again, I don't want to say you never do it because there are situations where you might, but I would bet for most of you, you're never going to see it given in anything other than a central line in your career. The situations I saw were very specific in particular and kind of weird. So the reason for that is because this is a very hypertonic solution. It's not good to give through peripheral IVs because they doesn't really go in very well. It also puts you at increased risk for a lot of complications like phlebitis, irritation of the site. It also, they oftentimes can't accommodate the large volume and again, the tonicity of the fluid. So we want to give it through a central line. And again, the situations where I've seen it was just these really odd situations where people needed PN for a very brief window of time. But usually when people are getting it, they're getting it over a longer period of time. If we were going to give it through a central line, which we should, which lumen do you think? And again, you can pause it, try to think for yourself, and then I'll give you the answer. So the answer would be the distal lumen. So there's obviously the proximal, the medial, the distal. The distal lumen is the lumen that empties closest to the heart. And we want to give it through that lumen if possible, because since it's closest to the heart, that means the vein is bigger there compared to anywhere else in the central line, where the lumen's emptying out into. So that means it's going to be best able to accommodate the hypertonic fluid at that location, right? So it's going to be best to give it there if we can. If you give it peripherally, which again, you probably won't, you just want to check for phlebitis because it can kind of ruin your IVs. I already mentioned this, but another reminder, the lipids are good for 12 hours. The hyperal is good for 24 hours. So once you hit those marks at 12 and 24, they have to come down, even if there's still some fluid in them, even if they're not totally finished, you still got to take them down and either swap it out for new bags or discontinue it, or do whatever the order calls for. We want to keep all of this material refrigerated until the moment we're going to use it, because once it's out of the refrigerator, the suspension starts to break down. That's why they're only good for the 24 and 12 hours respectively, because they're at room temperature hanging. And so as soon as they're up, the suspension is going to start breaking down. So we keep them refrigerated until we're going to use them. On the nursing side, we do not add anything to the TPN. We do not inject or put anything into those bags. I say that because the pharmacist might add things to the suspension as part of the orders, but we should not, right? So, that with our IV solution, sometimes we do add medications to IV bags. We never do that to TPN, never. Have to change this. Isn't anything that you wouldn't do normally. Hopefully you're changing your IV dressings per orders, and monitoring the site per orders as you should be anyway. But with TPN, we really want to make sure we do it, and we want to make it a priority because there's an increased risk for complications of central lines like CLABSIs, central line acquired bloodstream infections, with the administration of parenteral nutrition. And the reason is because we're giving a really highly, sugared substance through the IV. And so it can create optimum conditions for bacteria to grow, right? It's it just makes it easier for bacteria to grow because there's a bunch of nutrition basically going in. It's giving them a bunch of sugar and stuff. So if any of it's there, it can basically give it all the nutrition it needs to grow and form a bloodstream infection. So we really want to pay attention to the site. We need to educate the patient and family about the PN. What I mean by this specifically is that you'll see in the hospital, and some of y'all have maybe already experienced this, patients that are in for a long enough period of time, even sometimes for a very short period of time, they start to learn things about the pumps and about the room and about just nursing in general, such that you'll have patients and their families that will disconnect themselves from IVs, or they'll stop their IVs, or the IVs keep beeping, and so they'll learn which one's the silence button and they'll push it just to keep it quiet until somebody shows up. We want to ask people they shouldn't really be doing it to begin with, but we all know that people do end up doing this. You know, we've all seen it. So we really want to make sure they know not to do it for the PN, because if they disconnect themselves, or if the pump is not functioning and it's beeping and they don't like the beeping, so they put it on silent and we don't hear it and it goes an hour or something without running, that means they lost an hour of the nutrition they're supposed to be getting, right? So they're not getting what they're supposed to be getting. They're being malnourished, basically, right? And so for especially for long periods of time, they're not getting what they're supposed to be getting, and so that can create issues for them. That can lead to problems in nutrition, right? Some other things too. The bags expire. The lipids and hyperalk expire. They all have an expiration date on them. Check the expiration date, please. Make sure that they're in date. Don't just check the expiration date, though. Also check the bag itself. Look at it. Look at the contents and see, are you seeing sediment developing, or are you seeing separation, right? Because what will happen is the different parts of the suspension will start to separate from each other. And you know, you can almost think of it shouldn't hopefully look this gross, but if you were to take a bottle of milk or something and put it outside for a day or something, or if you were to like leave it in the back of your fridge for like a month, and you come back to it and you see that it's like separated out the liquid from the like the fats and everything, that's kind of what's happening, right? It's like the different components are separating out. So you want to check for, do you see little signs of does it almost look like there's little specks in it, or does it look like there's maybe little bits that are starting to form? That's sign of separation, right? The other thing, we give TPN, we give the hyperalk, we give the lipids as they are ordered. So in other words, if a new bag is ordered while the old bag is still running, we stop the old infusion, we start the new one, even if there's still 1,000 milliliters left in it or whatever. Same thing if the cycle is over, it's 24 hours and it's time to take the bag down, it doesn't matter how much is left in the bag, we replace it, right? So I'm saying all this because typically when we have something like normal saline that's running as like a maintenance fluid, if a patient's getting 100 mils normal saline every hour just continuously, the normal saline bag starts to get low, we swap out the bags. That's all we do, right? That's what we get accustomed to doing with a lot of IV solutions, especially ones that are running all day. With the hyperalk and the lipids, doesn't work the same. The hyperalk runs all day, but we don't just wait until the old bag is finished before we hang a new one, because one, they're only good for 24 hours, that starts to separate and the suspension breaks down. But two, every day, the physicians and the medical team should be updating the orders. So they might not change, but they're reviewing them. And what that means is they're assessing, okay, is what we're giving them enough or too much or whatever? And so they might change it so that tomorrow or today's new bag that comes when the cycle starts anew, that it has slightly different components, that the amount of something or something else is different than the one from the previous day. And so we don't want to keep giving them yesterday's, one, because it's expired, but two, because it's not the correct order, right? It's also very common for them to change the order throughout the day. So in other words, for the rate, excuse me, throughout the day. So in other words, patient might be getting it at 70 and the physicians take a look and see like, oh, that's way too high for whatever reason. So they might order you to change the rate down to 63. And so then you immediately update it. So just pay really close attention to your orders and make sure you're doing everything correctly. Yeah. So again, we cycle the TPN. We usually give it over a 24-hour period, but it could be less. Specifically, we might do a 12-hour cycle. The 12-hour cycle can be useful sometimes for patients who are getting this long-term at home, which basically means instead of being hooked up to the IV for 24 hours, they're just hooked up for 12 hours. So they can hook themselves up when they're at home in the sleep. And then when they get up, they don't have to be hooked up to the IV, while they're awake and everything, or at least as much while they're awake. We usually start the cycle at night for a couple different reasons. One, as I just said, if you're at home, it's easier for your quality of life to have the IV running while you're asleep. And then, you can do whatever you want during the day. In the hospital, we do it because what happens is we start the cycle in the evening. When we draw labs in the morning, the physician can then look at those labs and make any order changes they might need to be made to the order that morning, such that now throughout the day, the correct concentrations and things that are needed can be prepared by pharmacy, so that then tonight they get that new order, right? So it gives basically time so that the order can actually be changed, right? Because if we did it in the morning, you'd have to wait a whole 24 hours before you could really change the cycle. Because, all right, you started, the labs you got would have been from, a couple hours ago, so they're not really reflective of what you're getting now. It's not, it takes, it's not good, right? It's not going to be super accurate. It's not going to be really reflective. So again, that's why we usually start the cycle at night. So that means the night shift nurse is usually going to be the one who hangs a bag of Hyperal and a bag of lipids if they're getting the whole shebang, and it's going to run for 12 hours. Usually, depends on the institution, but sometime around the normal med pass time, so 8, 9, or 10, somewhere in that range. Then what will happen 12 hours later, when the day shift nurse comes on, you're likely going to take down the lipids, or take it all down if they're on a 12-hour cycle, or take down the lipids and put a new bag of lipids up if they're supposed to be getting the lipids for 24 hours. Basically, just you're managing it, right? You have to just double check and see, like, does anything need to come down? Does anything need to stay? Okay, right? And then do whatever you need to. Then the night shift nurse comes back. They're going to take everything down. No matter what, they're going to take everything down, because it would have been up for at least 12 hours in the case of the lipids and 24 hours for the Hyperal. That means none of it's good. And they're going to start the whole thing over again with new tubing, new bags, new everything. Anytime you hang a new bag for TPN, you use a new line as well, because again, the lines are only good for that one bag. Now, some other things that we do when we start somebody on parenteral nutrition, especially total parenteral nutrition, it is not always followed, but it can be really important in some situations to do what's called scaling up and scaling down, which basically means you start at a lower rate and build to the desired rate that you want. And then same for stopping it, you slow down the rate. So you start at the rate and then you kind of scale it down until you get to the rate you want, or until it's stopped. The reason is it can help prevent hypo and hyperglycemia. It kind of gets your pancreas used to that, marathon versus sprinting dynamic of when to produce insulin. It also helps prevent a really serious complication known as refeeding syndrome for those who are at risk, which we'll get to in a second. It's not always necessary, but generally it gives better outcomes for the patients. So the most common complications you're going to see are just hypo and hyperglycemia. Again, usually patients who are on parenteral nutrition, they have Q6-hour glucose checks. So we don't do ACHS like for diabetics, because guess what? They likely are not eating. So we can't really do it before meals because they're not eating meals. So instead we do it every 6 hours, which means we're still doing it 4 times a day, just like we would do for AC and HS, but just, every 6 hours instead. The other one's phlebitis. If we're using a peripheral line, again, it's not likely, but things like CLABSIs, things like that, that's another complication. And then fluid and electrolyte imbalances, right? Because again, it's changing our fluid and electrolyte dynamics. So we have to monitor those things. They need to be on strict I's and O's. One thing that I'll just mention before I get into refeeding syndrome, the Hyperal bags may have extra fluid added into them, or they may not. So it's important to know that, because if a patient is getting total parenteral nutrition and it's just the hyperalimentation fluid and just the lipids, they still need fluid, right? They still need fluid. Like when you go to eat, you don't say like, well, you need 2,000 milliliters, give or take, in a day, 8 glasses, 64 ounces of water. You wouldn't like eat 3 cheeseburgers during the day and be like, oh, that's great, I got my water in for the day, right? I got enough water. Now there is fluid and water in even solid food, right? But not it's not really hydrating you, right? So if there's no added fluid to the hyperal, which is where it would be added, they're going to have to be on IV fluid, and it's going to have to be enough to meet their fluid intake needs as well, right? We keep track of the hyperal and the lipids as they enter the body, but if there's no fluid added in, it's not really correct to think of them as like fluids. It's more correct to think of them as food, right? It's more like their intake for the day, because everything that's going in is being metabolized. Now, if there's added fluid, that's different. And again, a lot of times you will have TPN that's delivered where the fluid is added into the hyperal bag, but not always. So again, just be aware of that. Now, the biggest complications that you would see, now these are not the most common, but they're the most kind of serious, would be things like eclampsia or potentially a embolism, like either a sediment embolism or an air embolism or something like that. Another big one that's very specific to TPN, because you've learned about those others before, is something called refeeding syndrome. This is a problem that you'll only see in very specific like patient populations. It's generally something that happens to patients who are suffering from chronic nutritional insufficiency. So patients who are on like long-term cancer treatment, like chemotherapy or other things that have really just caused them to become anorexic or cachexic or something like that, that can predispose someone to it. Someone who's had a lot of like recent vomiting, diarrhea that haven't been able for a long, chronic period of time where they haven't been able to keep things down. Another common place we'll see it is when alcoholism. And the reason is people who are suffering from alcoholism, they oftentimes, not always, but oftentimes they drink a lot of alcohol, obviously. A lot of alcohols have a lot of calories in them, right? So if you look, I don't know how much like a beer has, but it's about, like probably 100 to 200 calories in it or something. Every gram of alcohol is equal to about 7 calories, if you remember your nutrition. Carbohydrate is 4, if I'm remembering correctly. And then your protein and your lipids are 9 calories for every gram. If I'm wrong about any of that, please let me know and make fun of me. But I'm almost positive that's correct. Alcohol, again, if I'm correct, is 7 calories per gram. So it's pretty close to your fat and protein, which are the more calorie dense nutritional components. So you're getting a lot of calories, but the problem is, while alcohol is high in calories, and it also has like a lot of carbohydrates in it sometimes, depending on how it's being made, right? Like it's, it has a lot of added sugar and stuff. There's no vitamins, there's no minerals, there's not really a lot of nutritional value to it. It's just alcohol, right? So that's a lot of times where you'll see it is patients who are coming in for alcoholism or other issues like that, where this can be a problem. And what's happening is the syndrome is characterized by fluid retention and electrolyte imbalances, because essentially what's happening is, in order to metabolize the nutrients that your body gets, your body has to go through metabolism. It has to basically burn energy to use the energy you've given it, right? It's kind of like, to start a fire, you have to expend effort and energy to begin that energy, right? It's kind of like you got to spend money to make money, right? Like that old saying. Your body has to use energy and electrolytes and things to start the process of metabolism, which will then get you access to more nutrients and things, right? So one of the problems that can develop is you haven't eaten, you have been starved of all these nutrients for so long for whatever reason. So your body, your electrolyte levels are all very diminished. Your serum electrolytes are very low. Well, then all of a sudden you get this influx of food, right? And your body's like, oh my God, finally we're getting fed. So like time to turn on the furnace and get things burning again, right? So all of the electrolytes and metabolic components of your body, they start shifting into making this metabolism happen, which means your serum levels drop even further, right, than what they were, because your body's like, mobilizing all your serum electrolytes to start jumpstarting the cells to go through the cellular metabolism. And so it leads to potentially this refeeding syndrome. Another way you can think about it, the kind of way I like to think about it is it's kind of like if you don't eat for like a day or two, and then you go to like the all you can eat buffet and you just start eating and then you like feel terrible. It's kind of like what's happening with your body. Not exactly, but I'd like to imagine that's like how your body feels, where it's like it hasn't been prepped, it's doing too much too quick. And so the signs of this, the hallmark sign, and it's why I mentioned it, I had as one of the options in that previous question I gave you, is hypophosphatemia. Now, hypophosphatemia is less than 2.4 milligrams per deciliter of phosphate in the serum. I include that value because I know it's not one that y'all learn very often. It's not one you see very often. Like potassium and sodium, if I were to ask y'all that, you know it off the top of your head. Phosphate's a little more niche. It's not something that you have to think about as much, as often. It's not essential to as many meds. So the reason is because, again, all the phosphate in your serum's being used by the cells and things and to start cellular metabolism of the nutrients you're getting. And so the hallmark signs that you'll see are muscle weakness, muscle spasming, confusion, loss of consciousness, just mental status changes. And again, like muscle weakness, muscle cramping, muscle stiffness, muscle spasming, things like that. So those are signs you want to look for. So again, it goes back to when we're giving somebody parenteral nutrition, we want to be checking their serum electrolyte levels and their fluid intake, because this is one of the major complications they can have. It's not very common that it happens, but it is important to check for because it's serious. It's a really bad critical complication that can develop. But it's also one that is relatively easy to catch if you are paying attention. It's also one that usually can kind of fix it. All we have to do is just decrease the rate. It's like you start them off giving them a little bit, and then you kind of work your way up to the point we want. That's why the cycling up and cycling down is so important in some situations, not all, but in some. So again, some things to think about when we're doing our assessment. We want to check their weight, their isonos, their general nutrition, how much are they taking in. We want to check all their serum electrolyte levels. We want to check all their blood glucose levels, and we already talked about why that is. We want to check their albumin and especially pre-albumin levels. We talked about that because it's a really good measure for their nutrition status. We also want to think about, why is the patient getting this? Like, what is the reason they're getting this therapy? Obviously, they're getting it because they need some parenteral nutrition, but are they getting it because we're trying to give, like, they're able to eat, but we're trying to increase the amount of protein and other nutrients they're getting to help with like tissue healing? So in other words, like maybe somebody's got, really bad burns or something and they're able to eat, but they have to do a lot of wound repair and they have a lot of tissue healing. So we want to give them even more nutrition because, again, it takes a lot of energy for your body to repair tissue. It could be that maybe the person is anorexic because they've been on chemotherapy for a long time and it's made it very hard for them to keep food down and stuff. So they're able to eat, but it's not adequate. And so we're trying to encourage them to eat as much as they're able to tolerate, but we're going to use the TPN, or the PN in this case, to ensure that they get adequate nutrition. And anything above that they eat, that's just icing on the cake. That's awesome that they can do that, but we're going to ensure that they get the bare minimum right through the PN, because then there's not an issue, right? And then maybe they've had gastric surgery and they're not going to be able to start eating again for 2 weeks. So in that 2-week period, all their nutrition has to come from this. And so it's going to go through here. And then maybe, I'm just creating scenarios, but yeah, maybe they had a gastric surgery where we had to remove a loop of their colon, or maybe we had to do something that meant their GI system couldn't function, but now they have a G tube in. So we're going to start giving them tube feeds. So maybe during that 2 weeks when their GI system isn't functioning, they're getting TPN. It's all going through the parenteral route. Then their G tube is in, it's healed, their GI system starts to work. Then we start giving them feeds through their G tube, right? And so while we're doing that, we're keeping the PN going, but we're slowly scaling the amount, the rate down, while we try to increase every day how much we're given through the G tube, right? And so we're kind of transitioning them off of it, right? So it's always just think about, like, what am I doing? What are my goals? Why are they getting this? When realistically are they going to stop getting it? What are the conditions that would arise that would lead them to stop getting it? What might necessitate them getting more? Just think about all those things. Now, the last thing we're going to do, these are just some scenarios I want you to think about. Just most of them are pretty self-explanatory, but yeah, you find yourself in these scenarios. What might you do? What do you think would be, best action? There isn't necessarily a perfect answer for all of them, although I think there's a lot of potential answers for a lot of them. Some of them, though, it's pretty straightforward what to do, but just some things to kind of think about, like, okay, if I'm in the situation, what would my next step be? And then the last thing, just if you want to, if you can, think of what would be some nursing problems or patient problems. I have nursing diagnoses in there. That's because I'm a dinosaur and I remember using the Dingy's, official like nursing diagnoses, but we don't really use those anymore. So what would be some patient problems that you would expect to include in a care plan for a patient who's receiving parental nutrition? What would be the problem we would have? And then what would be some goals for that problem? And then what would be the steps or interventions you would use to meet or to achieve that goal, right? So just try to think a few of those, see if you can figure out what would be my priority nursing or patient problems I want to address? What would be the goals that I would want to set? Again, you can't be super specific because we're talking in generalities, but yeah, what would the goals look like? Is it a problem of, just to give one, like nutrition requirements that are less than their body needs? So, and decreased nutrition or, nutritional requirements that are less than what their body's currently at. So then our goal might be something like, they're malnourished. So maybe our goal is the patient will gain 1 pound in a week, or maybe it'll, by the discharge, they'll have gained 5 pounds, or maybe it's that, in a couple of days or whatever time frame you want to use, the patient will be receiving 2,000 calories every day. There's a lot of different goals you could set. And then what would our interventions be? And then they might be, again, ensuring that the TPN is running effectively, monitoring their serum electrolytes, monitoring their prealbumin, all those things. I'm not going to go through the entire problem, but that's just an example of one. There's a lot of others you could choose, but it's just a way to kind of think through, how would I write a care plan for a patient getting this? So with that, I think that covers it for TPN. If you have any questions, please ask, email, or use the Canvas discussion board. But yeah, you can also email me, fine either way. And yeah, good luck on your tests, good luck studying, and good luck on all your other content this semester. And yeah, hope you'll have a good one.